And good evening, midwives and student midwives. Well, from wherever you are in the world, welcome to the Maternity and Midwifery Hour. My name's Sue MacDonald. I'm the curator for the Maternity and Midwifery Festivals and the Maternity and Midwifery Hour. And it's my pleasure to be chairing the session this evening. And we've got one special speaker, which is fantastic, which is Julie Abayomi. And I hope I've pronounced that correctly, Julie.
You have, thank you.
This is one of the problems because we always talk to each other with first names, so when you come to second names, sometimes you're not quite sure, but welcome, Julie. Now, we always do this with our guests. We always welcome them and get them to share their moment of the week, which is a nice way of starting us off. So, Julie, do you have a fantastic moment of the week to share with us?
So I think the highlight of my week so far has been I've finished marking my master's students' dissertations, and there's some really fantastic work in there. And they've all chosen maternal health topics, which is even better. So I've enjoyed marking them and seeing all the work that they've done in this area.
Wow, that's fantastic. So, lots of people doing very well then.
Yes, yeah.
Fantastic. That's really lovely, actually. It is always lovely to see people's work and they've put their heart and soul because that's part of the whole master's transition, isn't it? Put the
Yeah.
heart and soul in a piece of work, which is really great to mark. So thank you for sharing that. That's fantastic and a good moment to share. Okay, well, I'm going to just go through the usual bits and pieces. And I do want to say a big thank you actually to Hannah Tizard, who was looking after the maternity hour last week. And I have to say, it was a real treat. It was a very sad topic of baby loss, but it was really beautifully handled, very sensitive and compassionate, and really important for midwives and students to know about, student midwives to know about. So thank you to Hannah and Mark and Lisa. That was really good. Um, and I also want to say a big thank you to everybody for coming this evening. I know we'll have some new people and we'll have some people that know the maternity and midwifery hour very well. So welcome. And you will all know that we started at the beginning of the pandemic, the COVID-19 pandemic in 2020, which seems in some ways a lifetime ago, but it's not that long. Because we needed to replace temporarily the study days, the conferences, the festivals, and we couldn't do face-to-face things. So we started having one session an hour, over an hour every week, really to share what was happening in maternity and midwifery, all lots of good practice, but also how people were coping with such a major events such as a pandemic and what fantastic and very creative things that midwives and students were doing to cope with things, but also try and provide good care to women and their babies. So it was really a very important time. And we've kind of carried on because, of course, COVID's still here around, but it's not the way it was. And we obviously don't have lockdown. So we've had now a lot of face-to-face festivals, which are fantastic. Another one in November in Edinburgh. Put your name down for it immediately. We're also, I need to remind people, everything's recorded and it's kept and looked after by Matflix. So if you miss anything or you want to access things, you can access it through the Matflix if you don't access it through YouTube or any of the other channels. And I think there are some really good deals at the moment if you want to subscribe. If you're not part of a university or maternity service that actually already subscribes. So check your maternity unit or your university so you can see if you can get access to everything for free. There's lots of things like box sets which have little reflective activities and additional materials which are all presented by Dr. Jenny Hall. Really useful for those of you midwives who are doing your revalidation, but also if you're a student midwife doing any assignments or dissertations, really very useful because you can find the information. Most things are recorded and as presentations, and it's a really good way of understanding things and enjoying topics. I mean, it's like today we're going to hear some research hot off the press, and I think it comes alive when the person who's been involved in it is talking about it. So it's very special. And we love you to share. So this maternity midwifery hour, if you get a chance to share with your colleagues over the next few days, do so and make it part of your kind of routine of chatting to people and talking about what you've learned and what it means for you in practice, because that's how we kind of slot it into our brains. The trouble is we're really busy people. Our brains are full, our hands are full a lot of the time. So the more tools that we can use to help us learn and remember things, the better. So that's certainly how I remember things, by sharing. So do that. I'm going to say a big thank you to all the students and the midwives now for all the things you're doing at the moment. As you always do, fantastic. Keep up the good work. And I'll look forward to meeting some of you at the next festival. And I also need to actually, because having had a horrible cold the last couple of weeks, I want to remind you to look after yourselves as well, just as you look after women and babies and families, because you're really important and you're important to your family and your friends as well as the women and babies. So care for yourselves as well. Now, I'm slotting over to the news now, and it's Black History Month. The theme is reclaiming narratives, and there's been quite a lot of stories. If you look at things like Facebook and if you look at Twitter, there's been some really good stories of what to Black history, which I always find come alive again, because as a midwife, I love stories and I can learn a lot about history, and it becomes real. It becomes real when you hear someone talking about what it's like or what it was like, especially when people have come over and worked in the UK at a very different time, and how they've seen the things transition over the years. So also Domestic Violence Awareness Month, and there's materials available via Baby Buddy and Safe Lives. And we're going to be exploring that next week with two of the speakers, which I'll remind you at the end of the hour. Now, last week was the Pregnancy and Infant Loss Awareness Day. And there was also, there's been quite a lot in the media about the problems with babies being discovered having been in a mass grave rather than being buried with somebody or in their own little grave. And I know most of you will probably know this did go on in the past. But when you hear media stories, it becomes very intense, and it becomes more vibrant of understanding the impact on families and people who remember their little baby. And it was kind of highlights the long-term impact, I think. There was also the Wave of Light last night, 7 p.m. I hope some of you all have remembered and lit a little candle for the lost babies. And I know that was going on throughout the UK, which was really nice. And then the other story that I enjoyed and this was I think it was via Twitter. And I'm not going to say that other one, it's Twitter for me. After the hurricane in America, there was a really good story about women on horseback, and I suspect a lot of them were midwives or nurse midwives, and they were providing supplies and care to new mums, and they were a whole lot of their work was looking after making sure babies were getting safe feeding, safe food, making sure, because what was happening is because women were very anxious that their milk supply might not have been as good, but some of the mums who were using artificial milk were sort of watering it down a bit because they weren't sure if they'd have enough. So this whole team of women were going to make sure the babies were getting enough food and the mums were being cared for as well. They're also establishing milk banks, human milk banks, to collect and dispense milk. So really important part of kind of emergency work that has to go on. So good on them. And also I've got put two things on your resource list this week, apart from the wonderful references you've got from Julie. I have to say, lots and lots of reading. Now there's one, the newest Saving Lives, and this is the Embrace report. And this is, I've printed out the State of the Nation report, which is a shortened version. It's a bit like an executive summary, but I have to say it's packed full of information. I think if you're not clear on your understanding of the Embrace and confidential inquiries into maternal deaths and perinatal deaths, this really gives you a really good understanding of how the investigations go on, how they pick out information, and the recommendations very clear. So if you're in a rush, this is the thing to look at, and look at the key messages. And once more, it's inequalities in maternal mortality. So Black women, Asian women are more likely to die than white women still. It's reducing a little bit, but it's still an issue. But also areas of deprivation in the UK are also problems for maternal mortality. So it's a really good report, and I'm recommending it to you as your bedtime reading, or maybe not in your bedtime reading, but at some point in your time. The other report that I think is very interesting that was printed this week, so it's fresh off the press, and this is from WHO, World Health Organization, which is transitioning to midwifery models of care. And guess what? They're recommending much more about midwifery-led care, midwifery models, because of the impact on women and the quality of the care that women can receive, the reduction in maternal mortality and morbidity, and also improving long and short outcomes for mothers and babies, but also improving public health and reducing health inequalities. So it's quite interesting. The two reports are very kind of close in a way. And again, it's not a huge report. And for those of you doing anything international, really useful, really useful. And actually anyone doing anything on maternity and midwifery models of care, perfect for you. And of course, you see, almost perfect timing I have. I think the other thing that's been in the media a lot, and Julie and Neil and I were talking about it a little bit earlier, there's been a lot in the media about obesity and about using all the new drugs that they're using, which were originally for diabetes. And the idea of giving people who are obese all these drugs on the NHS so they'd be able to work. I'm not sure that all people who have problems with obesity or weight management are not working. I think quite a lot of people are working. So I think it's a bit simplistic. But we are going to look this evening at obesity and women living with weight issues. And I'm so pleased that Julie Abayomi is going to share with us her recent research and how we can actually use this in education and practice. Now, she's a reader in dietetics and an associate head of medicine and nutrition at Edge Hill. She's extensive experience in the NHS as an NHS dietitian, specialising in women's health and nutrition for over 12 years. And she was awarded a PhD in 2010 based on the research conducted at Liverpool Women's Hospital. She's also currently chair of the British Dietetic Association England Board and an active member of the BDA Maternal and Fertility Nutrition Specialist Groups. She's presented nationally and internationally and published extensively, including a fabulous chapter in May's Midwifery, edited by my good self, and most recently in the one of the publications she's going to be talking about in the International Journal of Quality in Healthcare. So welcome, Julie. Thank you so much for coming along this evening. The screen is now yours.
Thank you, Sue. Thank you for inviting me, and thank you for such a warm welcome and all your kind words. So I'm going to be presenting tonight a study that we published recently about the experiences of pregnant women living with obesity and their access to antenatal care. Oh, there we go. So what I'm going to cover in this presentation is I'm going to look at gestational weight gain and some of the recommendations about gestational weight gain, but also some of the risks with excess or inadequate gestational weight gain. I'm briefly going to look at weight stigma, and then I'm going to move on to the research that we did with pregnant women. And later on, I'm going to present my research that I've done with student midwives about nutrition education. And I've got the reference for the paper on that slide there in terms of the study that I'm presenting tonight. So by way of introduction, we know that pregnancy is often a time when women gain significant amounts of weight, and they often gain significant amounts of weight in a short period of time. Surprisingly, we don't have any UK official guidelines about gestational weight gain. So it's often quite difficult to advise women about how much weight they should be gaining during pregnancy. So a lot of health professionals refer to American guidelines in the absence of UK guidelines. So you may have heard of the US Institute of Medicine guidelines. So these recommend specific weight gain according to pre-pregnancy BMI. So the lower the pre-pregnancy BMI, the higher the weight gain recommendation. So if we look at women who would be classified in the obese category, which is a BMI of 30 or more, the recommendation is that they should limit weight gain to between 5 and 9 kilos across the whole of their pregnancy. And these figures have been decided by the IOM because they are the figures that show the best pregnancy outcomes for mother and for infant. So on this table here, I've got the IOM guidelines in more detail. So you can see that there are different weight gain recommendations based on pre-pregnancy BMI. So for underweight women, for example, with a BMI of less than 18.5, the recommendation is 13 to 18 kilograms. Not surprisingly, these recommendations have come under some criticism. I mean, a weight gain of 13 to 18 kilograms is a significant weight gain, possibly unrealistic for somebody who's underweight. And also the 5 to 9 kilos has been criticised because we don't have any recommendations that go beyond 30. So what about for women who've got BMIs in their 50s or the 60s? Are these recommendations the same, or should we be looking at different figures for these women? So in terms of what guidelines we have in the UK, these are a little bit more vague. So I've put some of the current guidelines on this next slide. So at the top of the slide, you can see these are the recommendations from the Royal College of Obstetrics and Gynecology. And they talk about women optimizing their weight before pregnancy, having weight advice during preconceptional counselling, and that any women with a BMI of 30 or more should be referred to weight management services after pregnancy. Doesn't really tell us what we should be advising them during pregnancy. It's all before and after. And then if we look at the NICE recommendations, again, it's about achieving a healthy weight prior to conception and avoiding dieting whilst pregnant. But they don't really explain what they mean by dieting in that context. So again, not particularly helpful. So because of this limited guidance, it's quite difficult for healthcare professionals like midwives and dietitians to know what they should be saying to women about weight management during pregnancy. So there are some risks associated with a very high BMI during pregnancy and also with excessive weight gain during pregnancy. So for pregnant people, there's a risk that they'll have postpartum weight retention. So if they gain a lot of weight during pregnancy, they're more likely to be overweight after pregnancy. They're more likely to develop gestational hypertension, preeclampsia, gestational diabetes. They're more likely to require a cesarean section, and they're more likely to have postoperative complications after the cesarean section. But there are risks for the offspring as well. So there's an increased risk of large for gestational age or macrosomia. There's an increased risk of shoulder dystocia, but there's also a risk for small for gestational age, and this is often related to placental insufficiency in women with a very high BMI. And these babies are also more likely to experience childhood obesity and to have complications of obesity and other non-communicable diseases in later life. We've also got risks of low BMI in pregnancy and inadequate gestational weight gain. So women are more likely to have a preterm delivery, to have anemia, and then babies are more likely to be low birth weight or small for gestational age. And interestingly, low birth weight babies also have an increased risk of obesity and non-communicable disease in later life. So it's a kind of double-edged sword, really, and optimal weight gain would be very important for reducing these risks. So I wanted to mention a little bit about weight stigma. There's been lots of studies that have looked at weight stigma, but this particular study was a scoping review that looked at particularly at antenatal care and healthcare professionals working in antenatal care. And they found that lots of healthcare professionals avoided having weight-related conversations with their patients. There were lots of assumptions made about lifestyle behaviour, and any communications about the risks associated with obesity were often handled quite poorly or insensitively. So this leads me into our study, which was to explore the lived experiences of pregnant women living with obesity during antenatal care. And we recruited pregnant women who had a Buckingham BMI of 35 or more. And we conducted semi-structured interviews with them. We recruited 18 women for this particular study, and the interviews were recorded and transcribed verbatim, and then we analysed the transcripts thematically. So we identified 4 themes from the study. So firstly, antenatal care is inconsistent. Additional support is needed for those with high BMI in pregnancy. Women feel judged because of their weight, and that weight cycling was highly prevalent in women with obesity. So I'm just going to mention a little bit more detail some of these themes. So in terms of the additional support needed for those with a high BMI, this was something that was of a particular concern during trimester 2. So women felt that when they booked in, they were given lots of advice, lots of information, often warned about the dangers of a high BMI at that point, but then they felt they were very much left to then deal with that problem, and there wasn't a lot of support in the middle of their pregnancy. So there's one quote to illustrate this is, once you get past the 5 months, there's no scans, there's nothing in there unless they think there's something wrong. In terms of women feeling judged because of their weight, there were lots of examples that women gave us where they felt that they'd experienced unpleasant or judgmental comments by various healthcare professionals. So one example here is about a GP, and the woman is saying that, I think the only thing is with doctors that because they put everything down to the weight part of you, and sometimes, you know, it's not. You know, like I went in one week and I was breathing bad and I had a chest infection, and he was sort of looking at me as if to say, it's because you're overweight. So they felt that any problem that they experienced, it was all kind of put down to the fact that they were overweight. And also the overall influence of obesity often led to anxiety and guilt in many of the women who felt that their weight had negative impacts on their baby's health. So one woman said she was anxious because obviously I'm putting my baby at risk because of my weight. So they were very aware of the risks and often felt quite anxious and guilty about them. Some of the examples of weight cycling, lots of women described to us kind of long journeys that they'd had in terms of trying to manage their weight. So they described difficulties in losing weight and maintaining weight loss. This was often described as a battle or a vicious circle. All of the women that we interviewed had previously tried to lose weight, many of them several times, and many of them had entered this weight cycling pathway where they lost weight and then they put the weight back on and often put more back on. And this was particularly associated with key life events that included pregnancy, but also difficulties in losing weight after pregnancy. So one woman said, my weight over the years has been up and down. I've dieted, I've lost weight, and then I've put it all back on again, plus more. And several women reported multiple attempts at achieving weight loss, and some of them used quite extreme regimes. So they talked about the stupid cabbage soup diet, or tablets that affect appetite, but none of them were able to report long-term success with any of these methods. So one woman said, I've tried everything, Weight Watchers, Slimming World, doctors, slimming tablets, gym, everything. Nothing seems to work. So I think the research has really highlighted a number of important points in terms of antenatal care. So I know a lot of antenatal services, additional support for weight management is often only offered to women with a BMI of 40 or more, whereas women with a BMI between 30 and 39.9, they've probably got just as much risk, but they're not offered any additional care during their pregnancy. They often only experience routine care despite having an increased risk. And many of the women that we've interviewed found that the routine care was really lacking following the booking an appointment, particularly for Paris women. So they described this kind of 8-week gap between 20 and 28 weeks. So I think for healthcare professionals, I think it's important for us to think about, if we're flagging all these risks with women, how are we going to reassure them in between, and kind of allay some of those fears and anxieties that they're experiencing due to their weight. Women also found that a lot of the conversations about weight to be both disrespectful and unhelpful. They reported being less likely to engage with weight management services if they'd had a negative experience regarding a lack of or a poor explanation of why the referral to weight management support was necessary. So, for example, some of them said, well, this letter just arrived in the post telling me I'd been referred, but nobody had discussed it with me. Nobody told me I was being referred. Nobody explained why I was being referred. And because of this, they were much less likely to engage with that weight management services. So I think it's really important for us as healthcare professionals to think about how we communicate with women about their weight. And what we say is never going to be neutral. It's either going to have a positive or a negative effect on them, depending on the conversation and the words that we use. So some recommendations following on from this study is, I think, the study shows that most of these pregnant women with high BMI are very aware that they've got a high BMI. They're aware of the risks, and they've had lots and lots of attempts at trying to lose weight before. So they might have quite a negative personal history of attempts to lose weight. And I think it also became clear that avoiding talking about weight is an example of weight stigma. So just referring people to weight management services without having a conversation or a discussion is actually another example of weight stigma. So avoiding the conversation isn't really very helpful. And I think all pregnant women need advice and support about diet and weight. And this is regardless of their BMI. If we look at things like optimal gestational weight gain, it's important that all women have a conversation about diet and weight. And I think if we're having a conversation with all of them, regardless of their BMI, it reduces some of those issues of weight stigma. And if you're concerned about having conversations about weight, I think it's always a good idea to kind of start by asking permission. So, is it okay if I weigh you? Would it be all right with you if we discussed your weight at this appointment? Would you be happy if I referred you to the weight management services or the dietitian? And I think that's a good place to start. So I'm going to move on to my second presentation now, which is some work that I've done with student midwives. And This is following introducing some dietetic-led nutrition education sessions to student midwives to see if it helped to improve their skills and their confidence to have more meaningful conversations about diet during antenatal care. So some background into this particular study, we know that UK antenatal guidelines say that midwives should discuss diet, nutrition and vitamin supplementation at booking in appointments. But earlier research that I've done with midwives and pregnant women found that none of the midwives that we interviewed had had any training about diet or nutrition in pregnancy at all. And they reported a lack of confidence and skills regarding advising pregnant women about diet and weight during antenatal care. So, you know, if we have this expectation that midwives can fulfill this role, but we don't give them any support and any training to do it, that's going to be quite difficult. So some of the conversations I had with midwives previously, they did recognise that having discussions about healthy eating was part of their role, but they also indicated that they didn't really prioritise those discussions. So they tended to prioritise other things over and above conversations about diet and weight. And one quote was, "We probably spend less time talking about diet and weight than anything else in pregnancy." And then I had interviews with postnatal women as well, asking them about their experiences of receiving advice from midwives. And you can see from these quotes that they found it quite a negative experience. So one woman said they just weren't interested in nutrition at all. It wasn't helpful at all. Maybe it was a lack of knowledge as well. They maybe didn't feel comfortable and they were just skimming over it. Another woman said they did ask, did I take vitamins, but didn't really give me more knowledge about the foods to get them from. And a third woman said they told me not to be eating lots of eggs and what to limit, food safety, liver and soft cheeses, that sort of thing, but didn't really give any advice about the kind of foods that women should be eating in pregnancy or would be important to include during pregnancy. So this has led me in my university where I work to develop a nutrition curriculum for midwives. And as Sue kindly pointed out, this work has fed into the chapter in the new edition of May's Midwifery. So I've written the Nutrition for a Healthy Pregnancy chapter. And a lot of this is based on the curriculum that I've developed for our student midwives. So in the first year, I introduce nutrition during a session with the midwives. So we talk about dietary reference values and food groups, key nutrients for fetal development and the dietary requirements for pregnancy and how pregnant women could achieve some of those healthy eating guidelines. Then in their second year, we talk about nutritionally vulnerable women. So which are the women in their care that are less likely to be achieving a healthy diet? How do we identify them and what can we do about that? And then in the third year, their final year, I have a final session with them where we have some case studies and we have some care pathways and we think about multidisciplinary working. You know, if this was your woman, what advice would you be able to give her about diet? And when would you decide, actually, this is beyond my remit as a midwife, I need to hand this on to somebody else? So we talk about referral for specialist support, when this should be done, and stress the importance of teamwork. So other research has shown that delivery of nutrition education for midwives can improve knowledge and skills, but as yet there's no evidence to show that an improved knowledge leads to a change in practice. So with my student midwives, I wanted to evaluate these nutrition sessions to see if it was likely to lead to a change in practice once they graduated. So I recruited the second year and the third year midwives during their taught session, and they were asked to provide free text feedback on anonymous post-it notes that are handed out during the session. So they were asked different questions in year 2 and in year 3. So in year 2, I asked them, how do you feel about offering healthy eating and weight management advice during antenatal care? And the third year students, I asked them, are these taught sessions likely to result in a change in your midwifery practice? And then I collated all the comments and analysed them thematically. So the results from the second year midwives identified 2 themes. So confidence about delivering healthy eating advice and nutrition knowledge. And some examples of this, about half of the students did say that they had increased confidence following the taught sessions. But a lot of them also said that they would still find it difficult to broach the subject with some women. So they kind of recognise some of the challenging scenarios, particularly for women who might be overweight, but they still felt that they might struggle with that. And they expressed concerns about causing offence, particularly in relation to providing weight management advice. So in terms of the nutrition knowledge, despite the nutrition education sessions that they'd had, a lot of them still felt that they didn't have enough knowledge and they needed to know more about nutrition as a midwife. Some of them also felt embarrassment or hypocritical about giving healthy eating advice, either due to a lack of enough knowledge or reflecting on their own poor eating habits. So a lot of them were saying, well, you know, I live on a bottle of Coke and a can of crisps. How can I talk to people about healthy eating? So that was an interesting finding. In terms of the third year students, 3 themes were identified from this feedback. So nutrition as a priority, personalised nutrition, and sources of information and signposting. So it was really positive to see that the third year students felt a lot more positive about nutrition than the second year students. And most of them commented that they now viewed maternal nutrition as important and they intended to prioritise discussions about nutrition in future practice. So I thought that was really encouraging. They also realised that messages needed to be personalised. So one student said, it has made me aware to tailor advice to different women. And I was really encouraged by this because I think previously there was a kind of a one size fits all type of advice. So I was really encouraged that they'd identified this themselves. They also appreciated that signposting women to reliable sources of information or other health professionals was an important part of their role. So they recognised that they didn't have to do it all themselves, that they could signpost to other people when they needed to. Again, very encouraging. So the results from this convenient sample of second year and third year midwives do indicate some really promising findings. It looks like by the third year, they recognise nutrition as much more of a priority. And they also recognise the need to focus on different areas of advice to meet the individual needs of women in their care. And the taught nutrition sessions are likely to result in a positive change in practice, supporting midwives to deliver what's recommended in UK guidelines. So I think nutrition education, which is delivered by a dietitian, and I think that's quite key because in terms of the care pathways and the case studies and the multidisciplinary working, I was really able to emphasise that for them. And that does appear to have empowered the student midwives to consider incorporating some of this practical advice into their midwifery practice. So I've included lots of references and reference list sent to Sue as well. Thank you very much for listening, and I'm happy to answer any questions.
Fantastic, Julie. That's really so interesting because I guess, I mean, we all eat, we all drink, but we kind of take it for granted. And I think the way that this second part, especially the research, really illustrated how it's a way of addressing not just diet and nutrition, but other things, getting people to think about tailoring the information we give. Because I'm very conscious that we do get into this thing of giving women a package of care. So give a package of information, this package of information for that, without necessarily working it through. And it sounded so good that your research was looking at something it was so critical as nutrition as a means of going all the way through. They're fantastic. Thank you so much. We have got some questions, and I'm going to say a big welcome also to Estonia, to Scotland, and Grand Cayman. I thought that Paul had said Grand Canyon, and I was trying to work out where midwives would be in Grand Canyon, but Cayman, and of course Qatar. So welcome to you all. We've got some questions coming through. So if you have a question at all, just pop it in the chat box and Paul will send it through. And we have a question. Some might be easier than others, Julie. We have very inquiring midwives here. The first is Maria Howe. Hi, Maria. And Maria says, is there any work planned to look at the risk of raised BMI, i.e. over 27.5 for global majority women? And I don't know what ethnic mix you had in the group you were looking at. I think that might be.
Yeah, so the majority of women in the study were white British women.
Okay.
And Maria's correct that there is some research that shows that we should be using different BMI cutoffs for different ethnicities. I don't think there's been any work that has looked at that specifically in relation to pregnancy. But it would be very, very interesting to look at that more closely.
Fabulous. Well, Maria, I don't know where you are as a midwife, but if you're wanting to do a piece of research, it sounds as though it'd be a fantastic piece of work using maybe some of the model that Julie used to kind of do a comparison. Fantastic. Thank you, Julie, for that one. And we've got Emma Rose. Hi, Emma. And Emma says, I'm interested to know what research identified a link between raised BMI and placental insufficiency.
I mean, I couldn't give you the references off the top of my head at the moment, but for example, women with gestational diabetes who have high BMI or excessive gestational weight gain, there's a lot of evidence of placental insufficiency in gestational diabetes. And I believe that there is some studies that show high BMI and excessive gestational weight gain, that there is it can affect placental insufficiency as well, even in the absence of gestational diabetes, but I don't have the references to hand.
Not immediately. This might be more homework for Emma, actually, to look at. Actually, there's some fantastic references there that you can look at if that's an area of interest. But it's certainly something that is kind of accepted, isn't it? And I think probably if you look at the NICE research, I want to say package, but it isn't a package. I mean, they have loads of research underpinning. Have a look at the NICE. That might be your starting point for a quicker way of getting it. So thank you, Julie. And we've got Max. What care? Hi, Max. What care and research have been provided for non-speaking pregnant? I assume you mean non-English speaking pregnant women with raised BMI. That's a good question, Max.
It's a very good question. I'm not aware of any research that's been done in this area. I think there's quite a bit of research in other languages, kind of in London and places where they might have a more concentrated population of non-English speakers. But I'm not aware of anything in the Northwest where I am.
Well, I think you can assume that the information to women is going to be less than women in your study had, because you haven't got the access to language, which is such a simple thing. Well, it's simple and not simple, isn't it? Because the biggest thing is the assumptions that we make. You know, I've been guilty of myself asking women, do you eat a good diet? Oh, yes, yes, yes. Of course, I eat a good diet. And it's only when you ask them what they're eating and what did you have for breakfast this morning? What did you have for supper yesterday? Then you find out what goes on. And it's harder with a woman who doesn't speak English. But it actually underlines one of our speakers a few weeks back saying we need to make sure we have interpreters. And this is an area just as important as anything else in midwifery. If you need to talk about diet and nutrition to a woman who doesn't speak English, get an interpreter to be working with you. I think that would be I'll get off my soapbox a minute. I don't know if you wanted to add to that, Julie.
I used to find when I was a dietitian that for women from different ethnicities, even if they could speak English, they often assumed that if they described their dietary habits to me, that I wouldn't understand. They'd say, oh, well, you wouldn't know because, I have an African diet or I have an Indian diet. And they would often be quite reluctant to discuss it with you. But obviously, as a dietitian, we do know about these things. So it sometimes they just need a bit more encouragement.
Yeah. Yeah. So you can make suggestions about different sorts of fruit and vegetables, etc. Fantastic. Now we've got some feedback for Julie, and it's Eleftheria Tausani, who says thank you, and in big writing, thank you. And then we have Faiza Osman, who says, thanks, Faiza. Thank you. This is amazing work. Jill says, thank you. Excellent information. And that's from Dundee. Thank you, Jill. And Comfort Momo, hi Comfort, how are you? Says, do you have a plan to do the same on a larger scale? Goodness.
I would love to do something on a larger scale. So I'm actually I am applying for some research funding to develop a resource for midwives.
Fabulous.
So based on the work that I've done with the student midwives, I want to kind of get some research funding and put a team together that would include midwives and pregnant women to kind of co-create
a
useful resource that everybody could use. So keep your fingers crossed that I get that funding.
Because this is a really important piece of research. So yeah, fingers crossed for that. Thank you for that, Julie. That's really good. And then Sarah Kelly, hi Sarah, says, will there be a move to regular weighing of all pregnant women again? In 1989, I was weighed every week. That wasn't that long ago either.
Very, very interesting topic. And I've just reviewed the new NICE maternal and child nutrition guidelines that are currently being updated. And they don't talk about monitoring weight at all. And I've actually flagged this as an important issue because they're talking about the dangers of excess gestational weight gain, the dangers of inadequate gestational weight gain. But if we're not monitoring weight, how are we going to know if women are experiencing excessive or inadequate gestational weight gain? So it's something that I flagged in the draft guidelines. Whether that will be taken on board, we shall wait and see.
Well, if you don't know what you're dealing with, I mean, I loved that you're suggesting we're much more asking permission along the line. So it's something we're showing our respect and trying not to make a judgment, because it is easy for everybody to make judgments. So that, I think it makes sense to me. Joe DeGuston, hi Joe, from Ames, says, is the text in May sufficient for student midwives and practicing midwives, or do they need more? I think I might know the answer to this. What do you think, Julie?
I think it's a good starting point. And there are kind of suggestions for further reading in there as well. So it's definitely a good starting point. And if people want to know more, they are signposted to where they can find more.
I think you've done a module on the RCM e-learning site, haven't you?
No, I haven't. No.
Oh, maybe this is time for something on there. That would be very good. I somehow thought maybe I'm seeing into the future there. I don't know, Julie, giving you some more work along the line. And then we have Eleftheria Tausani, Are there any tools we can use as midwives to find out any nutritional problems and refer to a nutrition list? Sounds as though that's what Julie's organising, but
So there is a tool that's used in Europe. So it's been developed by the Federation of European Obstetrics and Gynecology, or FIGO for short. So they have a nutrition risk tool that's been developed by European dietitians. We don't currently use it in the UK, but again, it's something that I'm planning. So I've just applied again for some funding to do a pilot test of the FIGO nutrition risk score in antenatal care. So again, watch this space. Hopefully, if we can show some positive results from a pilot study, it could be something that we roll out more extensively.
I think Julie is going to be a busy person. But of course, you know the saying, if you want something done and done well, ask a busy woman. There we are. Okay, thank you, Julie, for that. And we've got Claire Cordingley. Hi, Claire. Student midwife. BMI is only a contributing factor of determining a person's health. It's such an outdated method. Will the maternity services ever move away from judging these women based on BMI alone? Good question, Claire.
It is a good question, and you're absolutely right. There are lots of limitations with using BMI because BMI is simply a comparison of weight to height. It doesn't differentiate whether that weight is caused by lean body mass or fat mass. It doesn't differentiate. So you could have somebody with a very high lean body mass would have a high BMI, but they wouldn't necessarily be overweight or certainly not carrying excessive adipose tissue. It's more lean tissue. Absolutely right that it is limited. The problem that we have is that we don't have any other way of assessing risk. So any other ways of kind of trying to look at body composition in terms of risk are going to be much more invasive or much more expensive. So in terms of antenatal care, we're quite limited in terms of what we can use.
But then technology moves so fast, who knows what's going to come in the next year or so. So
Yeah,
it's a good point. Thank you. And Joe again, Joe Dasguston says, thank you for this work, Judy. From a service user perspective, it seems odd to think the nutrition curriculum presented there isn't in place for all student midwives and CPD sessions. And that's absolutely so, isn't it, Julie?
well, that would be my dream if that, if that happened. Yeah.
I mean, it is pretty hard for midwives if they haven't had that education and training to know. I mean, because I mean, I remember in my old nursing days, this is how old I am, we learned all about all the different food groups and all the different vitamins and all the rest of it. But it has a different meaning when you move into midwifery, and there's so much that's been discovered since. So we need to see this everywhere. So people, hassle your educators about this. Now we've got also, and I actually did have a query about these days. I don't know if it's a query or a sort of comment. It's just that as you were talking, I was thinking, one of the biggest things with obesity or weight problems isn't that people are just being greedy. It's often because they can't get the right sort of food because they're poor. They're having to go to the food bank and get a load of things that don't necessarily include fresh fruit and veg. And even if it did, they wouldn't necessarily be able to cook with it. I mean, I assume that's all part of your training, I would imagine, but it's
Yeah,
complex.
absolutely. And I think, with the current economic crisis that we're experiencing at the moment, being able to buy a healthy diet is even more difficult.
It's tricky, isn't it?
One of the things I've been discussing with the student midwives is if you look at Healthy Start, which was designed to support women on lowest incomes with access to healthy food during pregnancy and after pregnancy, the value of that hasn't gone up for years. If you look at the price of food inflation and the formula milk inflation, the Healthy Start vouchers used to cover formula milk. They don't anymore. So things are actually more difficult for people on low income in terms of providing a healthy diet. And it's lots of other things as well, such as physical activity. If people don't live in a environment that's conducive to physical activity, very difficult to say to people, go for a walk or go for a swim. If you don't live in an environment where that's possible or affordable, it's not going to happen.
Maybe this is what should be addressed by our politicians, I think. Okay, now I'm bringing things to an end because I always say this is the fastest week, or fastest hour in the week. Sorry, and it's gone really, really quickly. And it's a comment from Shaza Castle. Hi, Shaza, or Shaza. She says, I'm going to be doing a service evaluation on women's experience of birth planning and labour care with BMI of 40 plus. 40 kgs plus. Oh, that's interesting. Need to share and link up with other people. Fantastic. Max says this is excellent research. Did you collaborate with the obstetric team? Obstetricians. I think that's what Max means.
I didn't collaborate with the obstetricians for these particular studies, but it was part of a larger study that was obstetric led. So the larger study looked at kind of weight change and pregnancy outcomes. And I was kind of looking after the nutrition arm of that study. So we've got a study that was published 2 years ago that presented the dietary data from that particular study, and then the paper that we published earlier this year was the qualitative study. So I kind of looked after those two arms of a larger study, but the main paper with the pregnancy outcome data was led by obstetricians.
This is often the way, a huge project nowadays. You have lots of different arms to it. Thank you. That was really helpful. And Sue says, aren't we treating the problem? There needs to be better education prior to pregnancy. In the Caribbean, this is also an issue around education. They're looking at medication, surgery for weight loss.
Yeah, absolutely. And I like to think of it that it is prevention in terms of if we get it right in pregnancy, we're preventing it for the next generation. Because we know that excessive gestational weight gain, high BMIs in pregnancy is more likely to result in childhood obesity and then obesity in later life. So a lot of the interventions for children used to be, when children started school, age 5, and then they realised actually that that's too late. And then it was, let's start interventions at age 2. And now they're realising actually it's pregnancy where this starts. So if we can get it right in pregnancy, we are preventing obesity in the next generation.
Absolutely. Because if we teach the mum, we teach the kids, don't we? Fabulous. Okay. I've got just a couple more comments. We've got Emma Rose again, who says there are studies which show that regular weighing contributes to increased stress in pregnancy. We also know that stress contributes to weight gain and poor maternity outcomes. We should only regularly weigh if there's reliable evidence that there is a benefit to this. This is kind of the jury's out a bit here, Emma, but I'll accept that. And Joe says, Julie, thank you for being so honest about limitations in current education. I'm surprised the NMC doesn't pick up on this, where proficiencies are not being attended to. I think it probably is in the proficiencies, but there can be assumptions, even in education, that everything's fine, and we all know about food because we all eat. Doesn't always mean it's good. And then another comment from Shazza, who's student midwife. Hi, Shazza. She says it's also a point that not all pregnancies are planned. Good point. Often conditions such as PCOS are associated with infertility and raised BMI, so women may not use contraception resulting in unplanned pregnancies with raised BMI, starting the circle of further gestation weight gain. And I think that goes back to what Julie's just said about getting it right in pregnancy. It's a really good window for us to educate and support women. And I want to say a huge thank you, Julie. It's been really fantastic and so interesting. My brain's sort of twinging a bit on this one, and I think I'm going to carry on thinking, and I'm sure that our audience are doing so as well. But as we've come to the end of the hour, so quickly as always, I'm just going to say a big thank you to Julie, big thank you to Angela, who's making sure this is all beautifully recorded and available for the podcast on Friday morning and for you all to access over the next week or so. And plus Paul, who's been feeding questions through to me and also telling me where you're all from. And please do that when you come on, because it's always nice for us as speakers and the chair to know where our audience are from, because it's a bit exciting, actually. That's lovely. So resources are available there with the Facebook. Do look after yourselves. Next week we're looking at midwifery response to domestic abuse, and we've got Anne-Marie Tierney and Fee McLaughlin from Safe Lives who will be with us next week. Also, don't forget, if you are a teacher or you're a student, we've got the Midwifery Education Student Experience Festival on the 13th of November, both together but kind of running alongside each other. Face to face if you're in Leicester or you want to go to Leicester, meet other students or other teachers, but also it'll be online, as all of our things always are. We've also got the Scottish Festival on the 26th of November, and you might think that's a long time off, but it's not. It's only 10 weeks till Christmas, someone said to me today. So that's telling you. We're in Edinburgh and it'll be lovely. So if any of you want a little break in Edinburgh, come to face, but if you want to just link in electronically online, you can do that as well. It's fantastic. We don't mind. And in the meantime, stay well. We'll see you next week. Thank you again to Julie. Fantastic. We've got fingers crossed for all these different funding things to come through to Julie and her team so she can carry on this fantastic work. So see you next week. Take care. Bye.